This mini lecture will cover the remainder of chapter 22, respiratory infections, and we will look at viral and fungal infections. We will start with the cold. There are a lot of different viruses that can cause the common cold. Rhinovirus, rhino meaning nose, is the most common cause. But we also have coronaviruses and adenoviruses that can cause the cold as well. Now, since the cold is so minor and not life-threatening, we don't tend to do any types of studies to determine exactly what type of virus is causing the cold. So we really don't know the trends in these. If we look at transmission, droplets, aerosols, fomites, and because these are viruses, they can remain in the environment for a few hours, not days like we see with some bacteria, but a few hours. They can remain on fomites, so doorknobs or tabletops or counters, okay? They replicate best at a temperature of 33 degrees Celsius, which is the internal temperature of the nasal cavity. The nasal cavity stays colder than core body temperature because it is open to the outside through the nose and the mouth. Once the virus comes in, it adheres to receptors on the cell, and then you start to get those characteristic symptoms of the cold. You get sneezing, you get rhinorrhea, which is a runny nose, congestion, so you may be stopped up or stuffy, may have a sore throat, may have a headache, may just have that malaise feeling, that overall feeling of not being well, and a cough. One thing you notice there, or you notice that's absent from the signs and symptoms, is a fever. You do not run a fever with a common cold, okay? It is a viral infection, so there is no specific treatment, basically just over-the-counter medications to treat the symptoms. So this is a picture of a rhinovirus. This is from a scanning electron micrograph, just a small, round virus, looks very similar to a lot of our other viruses. Now, when we get into the flu, we get a little bit more complicated. When we talk about the flu, there are three types of flu that you'll hear thrown around: flu A, flu B, and flu C. Flu A is what is responsible for the epidemics and the pandemics. So an epidemic is a widespread area where infection rates are higher than what we would expect them to be. Pandemic is a worldwide epidemic. So it's not just in one country or on one continent. It now has spread to multiple continents. Influenza A is the one that is responsible for the pandemics that we've had over the past, 100 years. Reservoirs, particularly birds, a lot of times when we talk about the flu, it goes hand in hand with chickens and geese. With influenza B, it's a less severe type of flu. It's not going to cause pandemics, and there's no animal reservoir. And influenza C we rarely hear about because it's very similar to a cold, doesn't spread like the influenza A or influenza B viruses to cause epidemics. So flu is transmitted from droplets and aerosols, can be transmitted via fomites, but not as big of a role as we see in some other respiratory viruses. Incubation time is 24 to 48 hours. That's why treatment depends upon the time it takes you to get to the doctor and get diagnosed. We usually see a peak from December through March. And one thing that sets flu apart from a lot of our other respiratory illnesses is we don't see a seasonal variation in tropical areas. Now, this year has been somewhat of a fluke, I guess we can say, due to COVID and due to all of the precautions that we are taking against COVID with, increased hand washing and sanitation and wearing masks. We really haven't seen the number of cases of flu that we would expect, because we're at the point now where we're winding down. We're pretty much at the end of flu season, but we didn't really see the cases of flu that we would have expected to have seen. Now, when we look at influenza, we have several different strains, because we have the H spikes and we have the N spikes. And I've talked a little bit about these. The H spikes are the hemagglutinin, the N spikes are the neuraminidase. H spikes allow the virus to be able to attach to the receptors on the cells in the respiratory tract. And then the N spikes play a role in the release of new viruses. Now you see that can be as many as 500 H spikes, which allow for attachment, and then about 100 N spikes, which allow it to basically hatch or leave the host cell. Now you see there that they're antigens, and we know that antigens provoke a response from the immune system so that we can produce antibodies. So you think, okay, well, we just get these antibodies to all of these different H spikes and all of these different N spikes. The problem, though, is that there are different types, allowing for 153 possible combinations. We have 17 types of H spikes and 9 types of N spikes. So when we talk about vaccines, that's why we get a flu vaccine every year, because the antibodies don't last as long as some other types of antibodies, and because we try to target which influenza strains are going to be in the population. So if you get a vaccine for H1N1, well, and then you get the H3N2 flu, you have no protection, because you haven't been vaccinated against those specific variations of H and N. So this is what the influenza virus looks like. You've got this kind of lighter colored center, and then going around the outside there, those would be where those N and H spikes would be located. Here's an artist rendering. You've got the RNA here in the middle. It's got the capsid and then an envelope, and then all of those spikes on the outside. And you can see why we call them spikes, because they stick up off the surface of the lipid envelope. Now we have antigenic drift and antigenic shift. So antigenic drift is a minor change. This is when you get a few H and N mutations that occur kind of within a given region. Those we don't worry about so much. Antigenic shift is when we get a major antigenic change. So we come up with some completely new combination of genetic material. So a new combination of H and N spikes. And this is what involves those what we call blender species. And these are animals, typically. So what would happen is we have a pig or a bird, and this particular animal gets infected with 2 different strains of the flu. And now you've got all of this genetic information that's there, and it kind of mixes around. And that's what we call them a blender species, because this genetic material mixes around and then can spit out something completely different that we haven't seen before. That's what happened back in, I guess it was 2009 with the H1N1. That was a new combination that we had not seen in a long time. It had not been in the environment for a really long time, and that's why it affected mostly younger people, because we had never seen anything like that. Older people, because there had been a pandemic of an H1N1 back in the 50s and 60s, older people were a little bit more protected against that 2009 strain than the younger individuals. And that's typically not what we see with the flu. We know that it typically affects the older individuals more than younger. So this image just gives you some examples of some of these blender species. You know, birds really are some of the major blenders, but we have other animals that can carry the flu and can serve as blenders, but typically it's going to be pigs and birds. So when we talk about antigenic drift and antigenic shift, it's kind of a situation of changing coats. And flu is not the only infectious agent that we see that does this. It essentially is your immune system gets used to a white coat. So they produce antibodies against the white coat. And as long as the white coat's around, then they can have protection. They can pump out these antibodies. But then it changes to a blue coat. Well, the immune system is stuck on this white coat. It has antibodies against the white coat, but now there's a blue coat. Doesn't have any response against the blue coat yet. So now it has to learn the blue coat. And it has to produce antibodies against the blue coat. This is why we need a flu vaccine every year, because we're constantly getting new viral strains that are put into the environment. And if you received a vaccine against the white coat and you produce antibodies against the white coat, but this year's flu wears a blue coat, then you don't have protection against that blue coat. Now, in the 2019-2020 flu season, so this would have been last year's flu season, there were 31,000 cases of flu A. Almost 24,000 of those was of the H1N1 pandemic strain. So it became a pandemic in 2009, and it's kind of stuck around. A lot of the flu A that we see is still this H1N1 pandemic strain from 2009. You'll notice here the markings or the codes here. So in the flu vaccine, you'll see there were 4 different strains in last year's flu vaccine. The first component here is the A or the B. Okay, so what type it is, where it originated, and when it originated, and then what specific combination of H's and N's do we have. Now, in 2020-2021, we changed up the flu vaccine. Now, you have to understand that the flu vaccine has to be prepared many months in advance. So we don't know what viruses are circulating at the time the flu vaccines are made, because we have to have all of these chickens laying all of these eggs, because each flu vaccine takes between 3 and 4 eggs, depending on how many strains are in it. So if you have a flu vaccine that is trivalent, that has 3 strains, then it takes 3 eggs. So if you talk about producing, 100 million doses, then you need 300 million eggs. And it takes time for these eggs to grow and for the virus to start replicating so that we can extract it to actually make the vaccine. So that's why it's not always right, why it's not always accurate. All right, moving on from the flu, we get into RSV, or respiratory syncytial virus. Adults don't typically have to worry about RSV. This is a disease that is mostly harmful for children, and there really is no treatment other than supportive treatment. What happens is it causes the formation of syncytia, which are these giant cells. Basically, cells start to fuse together. And in the lungs, we don't want our cells fusing together because we need them to be very thin so that gas exchange can occur rapidly. Once these cells start fusing together, it makes gas exchange harder. And so that's why you need oxygen administration for a lot of these children, because their oxygen saturation is going to decline. A lot of times children with RSV will be given antibiotics, not to treat the RSV, but to treat any secondary bacterial pathogens that can take advantage of the situation, take advantage of the weakened immune system, the weakened lungs, and cause a bacterial pneumonia. So respiratory syncytial virus is also caused by an RNA virus. This is a picture of the syncytia. Instead of these tiny little cells, now you have this huge cell, and there you'll see there's several of them scattered throughout here. This is going to interfere with the gas exchange. And here's some statistics. Can also affect the elderly, but we don't typically see that as much as we do from children. Now, one viral infection that if you're a parent, you are very familiar with croup. This one is a little bit different from the other respiratory viruses in that they tend to peak in the winter. Croup tends to peak in the spring or summer. Forms syncytia in the respiratory tract, so not in the lungs, but in the respiratory tract leading to the lungs, and can lead to what we call laryngotracheobronchitis. So you get an inflammation of the larynx, or the voice box, the trachea, and the bronchi. Can make its way to the lungs, but typically doesn't. The characteristic sign of croup is a barking cough. And if you're a parent and your child has ever had croup, you know exactly what I'm talking about here. It sounds like a seal, and it usually hits for some reason in the middle of the night, and that's what you'll be waking up to, is this barky cough. Humidifiers help, and so they recommend, going into the bathroom, shutting the door, turn on the shower as hot as it'll go, let the room fill up with steam, and let the child breathe that in. That helps to calm some of that inflammation that leads to the cough. Let me pull up a video for you of the barky cough. Give me just a second. Almost. All right.
One of the best ways to diagnose a cough.
Oops. Sorry about that. Not sure what happened there.
One of the best ways to diagnose a cough, and the way.
Here we go.
We do it is by listening. So let's listen to this cough. That's kind of a clue to whooping cough. With that, you get those long coughs. The problem is that they breathe because they're coughing so hard, and sometimes there'll be a little whoop at each spell, a little whoop, as they're gasping for oxygen back in, and that's one of the reasons children aren't getting oxygen vaccination. There's a vaccine against this one, so I don't see it nearly as much, thank God. So here's another type of cough. I actually hear this one over the phone a lot.
So you can hear that barky cough there. Kind of sounds like a horse seal. That is indicative of croup. And again, there's really nothing that can be done really to treat that. Just some over-the-counter medication, basically just treating the symptoms for that one. So the next one that we're going to look at, you think, it doesn't really seem like a respiratory illness, is measles. We consider measles a respiratory illness because it is spread through respiratory droplets. And it does kind of start out with some of those respiratory symptoms, sore throat, dry cough. So measles, the characteristic sign of measles is a red raised rash that appears on the face and then all over the rest of the body. This is called a maculopapular rash because it is raised. You can feel it. Now, measles is one of the most contagious or most infectious diseases that we have. A 98% chance of becoming infected if exposed to someone with measles. So it's very, very highly contagious. But thankfully, we have a vaccine for this one. And even though vaccination rates are not at 100%, we do have, in many cases, herd immunity for this one. It does go away. There really is no treatment for measles. It does go away on its own, but it can spread to the brain and cause something called SSPE, which can be fatal. So, a lot of times people talk about measles. Oh, it's not a big deal. It's just measles. But measles can be deadly. Just because we don't hear about it that often doesn't mean it doesn't happen. So one of the first things that we see with measles are these, what we refer to as Koplik spots. You can see here on the inside of the cheek, you have kind of these white areas with these bright red centers, and kind of some other white patchy areas down by the gum line. Those are referred to as Koplik spots, and those will precede the rash. So here is an example of the rash on the torso. You can tell by looking at it that it is a raised rash, so you would be able to feel this rash. We, of course, in 2019, we had a huge outbreak, started at Disneyland, and we see these every few years, every so often, we'll have measles outbreaks because, again, when your entire population is not vaccinated, you're going to be prone to outbreaks. So rubella is sometimes called German measles, but it's not measles at all. It's not even related to the measles, not even the same type of virus. But rubella, they used to link with measles because it's kind of similar. They're similar to one another, but rubella doesn't tend to be as bad. However, there is an exception, and that is to fetuses. Rubella can spread vertically, and if that happens, there's about a 20% chance of birth defects. There was an outbreak of rubella in the mid-60s, and 20,000 babies were born with congenital rubella. So here is the rash associated with rubella. You can see that it's in some places it's a little bit more diffuse, but in some places it's a little bit more closely together, but it's more red, not quite as raised as the rash associated with measles. Here's a child that's been born with congenital rubella. They will typically have the rash, and as you can see on this child here, and they are often born with cataracts. As you can see here, the cloudiness in the lens. So there was a big push in the 60s to get women vaccinated, well, to get children vaccinated, but to get women vaccinated so that they wouldn't have a child that was born with congenital rubella. Chickenpox, again, you may not think of these as respiratory illnesses, but they are transmitted by respiratory droplet. Chickenpox is caused by a herpes virus, the varicella virus, and it causes blisters to form, and the blisters or the fluid within the blisters can also be contagious because it will contain the viruses as well. Humans are the only host. So this is one that hopefully we'll be able to get rid of. We have a vaccine for it now, and hopefully this is one that we'll get rid of. Chickenpox tends to be relatively mild, but again, herpes viruses, they can travel all over the body. They live on the nerves. They can make their way to the brain. Varicella can cause encephalitis, and some children have died from the chickenpox. You see there 100 to 150 people died each year. The vaccine became available in 1995. Morbidity and mortality has decreased by more than 90% since the vaccination program began. So shingles is caused by the zoster portion of this virus. Occurs in about a third of people who have had chickenpox. Herpes viruses remain latent in the body. So what happens is you get infected, you have chickenpox when you're a kid, the virus never leaves your body, takes up residence on a skin nerve, and then it becomes triggered or reactivated, travels back down that nerve to the skin and causes a skin rash associated with that nerve. Now, zoster means belt. So when you see the shingles rash, it occurs like a belt around the body. Oops. So here are a few images here. And the reason for this is because of how the skin nerves are arranged. One skin nerve will kind of wrap around part of the body. And so if, depending on what nerve is triggered, depends on where that belt or where that band of lesions is going to occur. Now, another thing that can result here, you see, you've got the zoster, which is the shingles, and you've got this PHN. PHN is post-herpetic neuralgia. So basically what happens is a person can have an outbreak of shingles, or maybe not. Maybe they don't even have the blisters that erupt, but they start having nerve pain. That's neuralgia. And they associate that with the shingles or with that particular chickenpox virus. So post-herpetic neuralgia, you see as we age, the case rate of both shingles and PHN increase. And here's another. Cases have kind of been on the rise here. Shingles incidence rate per 1,000 people, and this is in the United States. We have seen an increase in all ages of shingles. Now we get into our fungal diseases of the respiratory tract. And our first one we have here is histoplasmosis. Histoplasmosis is very common in the Ohio and Mississippi River valleys. You see there about 60 to 90% of people who live in those areas have been exposed. Most of the time, people who are infected with histoplasmosis never know it. It goes away on its own. They never even know that they have it. But for some people, they get fever, chest pains, and a cough, and they'll need some type of antifungal medication to treat it and make it go away. So here you go. Here's your Ohio River in the upper portion of Kentucky there. It serves as the border between Kentucky and Ohio, Indiana, and Illinois. And then, of course, you've got the Mississippi River there. So this dark green is the highly endemic, so right where I grew up. And then you'll notice we're in the moderately endemic area here. So here you can see, around the Ohio River, you've got around the Mississippi River area here where we see cases. And this is some old data. New data has not been released yet for this. So the areas in red is where the estimate of where histoplasma would be most likely to be. And again, you see here's your Mississippi, all along the Mississippi Valley, and then along the Ohio River too. So another fungal disease is valley fever or coccidioidomycosis. Most of the time, again, there are no signs and symptoms, but fatigue, cough, fever, shortness of breath, headaches, rash. Only about 5 to 10% of people who contract valley fever ever have any of the serious complications. And again, most of the time it's going to resolve on its own. Here's the skin rash. It's a very patchy rash. Fortunately, we don't really have to worry about it around here. This is more endemic to the American Southwest, and that's where you see the highest number of cases. Blastomycosis, again, causes mild flu-like symptoms, self-limiting, but for people who are immunocompromised, it can become disseminated, which means that it can go basically systemic. It's rare, but it's always fatal. So here is an x-ray showing a nodule where the fungal spores have been inhaled. Mucormycosis, very similar to these others, can cause upper respiratory or lower respiratory infections depending on exactly where it comes in. And that one has an overall mortality rate of 54%, so that one's pretty bad, but typically seen more in immunocompromised patients. Same thing for aspergillosis. Here's again a lung x-ray showing aspergillosis in the lungs. The good news about most of these fungal diseases is that healthy people really don't have to worry about them. Another one, pneumocystis pneumonia, sometimes called PCP, only affects those who are immunocompromised. And you see there, this is the leading cause of pneumonia in patients with AIDS. Cryptococcosis, fever, fatigue, dry cough, but again, very dangerous for those who are immunocompromised because it can spread to the brain. So really with fungal diseases, healthy people really don't have much to worry about with those. It's mainly those who are immunocompromised that we have to worry about. And that concludes chapter 22.